Today we're going to present to you diarrhea and water sanitation in Uganda. I'm Lucie.
I'm Henry.
And I'm Jeanae. Diarrhea disease classification. So diarrhea is defined as loose watery stools 3 or more times a day. Diarrhea may be acute, which is the most common, and typically lasts 1 or 2 days. Persistent, which lasts longer than 2 weeks and less than 4, or chronic, which lasts at least 4 weeks. The main system of diarrhea is watery liquid stools. In addition, other symptoms include stomach cramps, fever, bloating, etc. Individuals or groups affected. Diarrhea is one of the most common illnesses in all age groups and ranks along with the common cold as a main cause of lost days of work or school. It affects people of all ages. It's not limited to any specific race or gender and can affect any age, and it can affect you at any time. Risk factors. So viruses are a main risk factor for diarrhea. Viral infections cause most cases of diarrhea and generally last approximately 3 to 7 days. Other risk factors include intestinal disorders or diseases, alcohol abuse, diabetes, radiation therapy, and even running. Here's a causal web. In the middle, you can see diarrhea. Direct causes of diarrhea include chronic disease, collection and storage of dirty water, which is important in Uganda because they have limited access to clean water, and the way they store clean water, or the way that they store water, is also unsanitary as well. Bacteria, viruses, and parasites, and other secondary causes that relate could be poor public health, and alcohol abuse, intolerance, allergies to food. Yeah, so here we go.
So I'm going to talk a little bit about Uganda. So the population stands at about a little bit less than 41.5 million people. The urban population is at 16.4%. For the ethnic origins, the Bantus constitute about 75% of the population in Uganda, and they live in the south. Then the Nilotic people, they live in the north. And then there are 5 major language groups. So the Bantu and Nilotics that I just mentioned, and then there's Madi Muro, Highland Nilotics, and Nilo Hermits. In addition to that, there are a lot of refugees in Uganda that come from the neighboring countries. The official language in Uganda is English, but there are also other languages that are spoken, such as Gandara, Luganda, Niger, Congo languages, Nilo-Saharan languages, Swahili, and Arabic. The majority of the population in Uganda are either Roman Catholics or Protestants. Roman Catholics are 41.9% and Protestants are 42%, and then the rest of the population is Muslims or other religions, have other religions. So the literacy rate is at 60.8%. The location, so Uganda is located in the African Great Lakes region in East Africa. It is bordered by Kenya in the east, South Sudan in the north, and then in the south it's bordered by Tanzania, Rwanda, and the Democratic Republic of Congo. Much of the South country is heavily influenced by one of the biggest lakes in the world, which is Lake Victoria right here. The most important cities in Uganda are also located in the south next to Lake Victoria. Kampala, the capital of the country, is also situated in the south. And finally, Uganda lies almost completely within the Nile Basin. For the demographics, Uganda has one of the youngest and most rapidly growing population in the whole entire world. Its fertility rate stands at 5.8 children per woman right now, and except in urban areas, the fertility rate actually exceeds women's desired fertility by 1 or 2 children, which really highlights the lack of contraception and the lack of government support for family planning and the cultural preference in Uganda for larger families. The high number of births, the short birth intervals, and the early age of childbearing in Uganda all contribute to the high maternal mortality rate. And gender inequities also make fertility reduction extremely difficult because women on average are less educated than men. They're not employed, and they usually have little say on their own reproductive health. So Uganda has been a source of refugees, but also a host of refugees for many years, whether it was for poverty or security or just to look for jobs. The immigration of Ugandan doctors and nurses due to low wages is also a really important issue right now because there's already a shortage of health workers in Uganda. Africans escaping conflicts in neighboring states have found refuge in Uganda since the 50s, and right now there's a problem because there's tens of thousands of refugees that Uganda has to deal with. For the healthcare systems, the Ugandan healthcare system has 7 levels. The first level is divided into 4. So it's the health centers, so it goes from 1 to 4. It goes from covering 1,000 people to 100,000 people, and then their roles are also different. So for the health center number 1, it usually focuses on education and prevention, and then the health center number 4 covers prevention, cure, rehabilitation, and emergency surgeries in addition to what the other centers do. The next level is the district health services, which typically cover about 500,000 people. And then the regional referral hospitals is the third level. So it typically covers about 2 million people, so it does the same thing than the others. But in addition to that, it also provides select specialty care and outreach services. And finally, the last level is the National Referral Hospital, which covers 27 million people, and again, takes care of everything that the others do. But in addition to that, they have comprehensive specialty care and research and training. Overall in Uganda, there is a lack of medicine and drugs. It even became a rallying cry for striking doctors. The Uganda Medical Association president even claimed that according to his study, there's 75% of hospitals in Uganda that lack medicines and drugs, and obviously it causes unnecessary death. Uganda also lacks paramedics and skilled health workers and an effective nationwide referral network. It also desperately needs a well-equipped emergency system with ambulances stationed at every facility, an air rescue service accessible to every citizen, and also a team of paramedics that are available at all times. And in addition to that, it would be nice to have emergency toll-free phone lines so that patients have easy access to the emergency dispatch centers. When it comes to national insurance program, there have been failed attempts. Currently, only employed Ugandans have a medical insurance, and their insurance doesn't really cover much. It only covers easily affordable diseases such as malaria. So it doesn't even cover dental costs. But what is most important here is that poor Ugandans don't even have insurance at all. And then for the causes of death, I have 2 graphs. So the first one is from 2012, and it's from the WHO. And that one is from the CDC, and it's from 2017. So the graphs are quite different. In 2012, you can see that the top cause of death in Uganda was HIV, and then it was respiratory infections, malaria, diarrhea, and stroke. And we can see that in 2017, diarrhea became the first cause of death in Uganda, which is a big difference from 2012.
I'm going to continue with the morbidity and mortality rates. In 2000, 315 out of over 40,000 deaths, neonatal deaths that is, were caused by diarrhea illnesses. Compare that to 2016, where only 190 out of only 37,000 neonatal deaths were caused by diarrhea. In 2000, 21,000 out of 157,000 post-neonatal deaths were caused by diarrhea-related illnesses. And that compares to 2016, where both of those numbers dropped to 6,000 out of 52,000 post-neonatal deaths. The Ugandan death rate is 55.9 per 100,000 people. Those numbers are specifically the numbers for diarrhea-related illnesses. That death rate, 55.9 per 100,000, is among the highest 43 in the world. Most of those 43 countries are also located in the continent of Africa. Globally, there are 1.7 billion cases of childhood diarrhea every year. The financial burden on Uganda. $147 million last year were lost due to premature deaths. $21 million are spent each year on diarrhea healthcare, and $1.1 million are lost each year due to a loss in productivity. The economic burden in Uganda disproportionately falls on the poor. This is because the poor have a higher reliance on government aid and help, and also since they have a smaller total income, the money that's taken out of that to pay is a larger proportion of their total income. There are also social costs related to diarrhea and diarrhea-related illnesses. Number one is the loss of productivity. In the last slide I mentioned that $1.1 million are lost each year due to a loss in productivity. So that's people not being able to show up for work and losing productivity in that way. Another social cost related to diarrhea is how diarrhea and a poor water sanitation system often leads people to practice open defecation, so going to the bathroom out in the open. The social costs related to this have to do with safety and particularly sexual assault against women. $3.9 million is lost annually in tourism in Uganda, and that's simply because travelers hear about the high rate of illnesses and disease, and they choose not to travel to that specific country. Lucie mentioned a little bit about the ethnic groups within Uganda, and I'm just going to elaborate on them a little bit more. There are over 40 different ethnic groups in Uganda. The largest group is the Baganda people. The Baganda people are also the wealthiest overall, and they're located mostly in central and western Uganda. The poorest ethnic group in Uganda is the Karimajong people, and they're mostly located in northeastern Uganda, which is an overall rural area. Overall in Uganda, the rich live in urban areas in western and central Uganda, and the poor live in the rural northern parts of the country. Children and rural inhabitants in Uganda are the most vulnerable. Children are the most vulnerable because they're young, their immune systems are kind of weak, and also they don't have knowledge to avoid certain sources of water or certain food contaminants and other things like that. Rural inhabitants are also vulnerable because they live on the outreaches of civilization, so it's hard for infrastructure to reach them sometimes, and also hard for aid and medical services to reach them as well. Rural individuals and households are overall less educated than urban households, and your ethnic group, like I talked about in the last slide, plays a role in your socioeconomic situation. The graph that I have here to the left breaks up people into age groups under 5 and 5 years and above. It also breaks them up into rural and urban locations, and then elaborates on their level of education received, and the graph shows that urban inhabitants have a higher level of education than rural inhabitants that were polled. Like I mentioned, rural inhabitants are more vulnerable because it's harder for infrastructure and aid to reach them. Most often this is due just because of simple things like roads aren't as built and they aren't as secure, and sometimes they're washed out. The climate in Uganda is tropical. This lends to a poor recovery because heat and humidity are an added strain on the body, and when someone is trying to allocate all their bodily resources to just getting better, heat and strain can kind of slow that process. The tropical rains in Uganda fall during between March and May, and also between October and November. During these months, Ugandans have access to a clean water source, which is the rain, and many of them utilize that as a substitute. But during the months that it's not rainy, they have to fall back on that substitute. Health disparities. In 2009 and 2010, the rural population was 27.2% poor. The urban population was only 9.1% poor. The north was 46.2% poor, and the north is mostly rural. And the central population was only 10.7% poor, and the central is mostly urban population. The central is a majority of Uganda, and it's also where the capital is. The north is mostly the Acholi people. The goals and priorities of interventions regarding diarrhea are mostly centered around children, since they're such a vulnerable population. International organizations as well as the Ugandan people have programs specifically aimed towards aiding children and helping increase their knowledge and recovery time from diarrhea. The education of families, mothers, and communities about diarrhea and how it spreads is also a very important goal. The more people know about it, the less it's going to spread and the less they're going to expose themselves to contaminants. Rural communities also are the hardest hit, so they've become a focus for NGOs and health organizations, both at the Ugandan national and local level, and also at the international level.
So the organization that we chose is PATH. PATH is an international health organization that was founded in 2006. The scope of their programs include, is larger than just water sanitation. They have other programs that focus on health issues like malaria, HIV and AIDS, and nutrition. On their website, a quote off of their website is, to develop low-cost, easy-to-use technologies that bring safe drinking water to humanitarian relief settings, schools, facilities, and communities. So their programs aren't just limited to Uganda. As you can see, they introduced a new rotavirus vaccine in Nicaragua in 2006. They've also done work in Cambodia, where they worked with the government to try to control the outbreak of pneumonia and diarrhea by increasing accessibility to healthcare. They collaborated with Cascade Designs to make a portable safe water systems device. The Safe Water Project is where they explored commercial market forces to distribute water treatment and educate on how to use these safe water systems. And also introduce latrines to low-income households in continents like India, and Southeast Asia, and East Africa. They also worked with partners to improve ORS and created a Defeat DD website where people who are interested in fighting these issues and advocates can get a list of resources on how to help and how to educate their communities on this disease.
So for our intervention, we got inspired by one of the YouTube videos that we proposed for the movie, and then also by Megan with her water quality management in Ecuador. So the objectives of our intervention would be to reduce the amount of people that have diarrhea from unsafe water, also shorten the amount of time to recover, and finally to increase the knowledge about diarrhea among the population. So the design would be to implement chlorine dispensers all around the community, because we know that chlorine kills about 99% of bacteria. So it would be a good option. And then also education to educate people on how to not contract the disease and how to best recover from it with the oral rehydration solution treatment, for example. So the targeted population would be the Ugandan population as a whole. For the setting, when it comes to education, it would be in schools and community centers. And the chlorine tanks will be placed near the water source so that it's easier to use it. And so who will deliver the intervention? It would be trained volunteers and health professionals. And then the chlorine tanks would be self-serve. And finally, for the time period, so for the assessment and establishing and implementing our project, it would last about a month, and then we would come back after 3 months for the initial assessment, and then after that every 6 months.
I'm going to go a little more in depth about the description of the intervention. So we'd like to start with an initial survey of the community to determine the presence of need. So this would basically be taking a poll over frequency of diarrhea, the population that is hurting the most, and other statistics like that. We want to do this because we want to have a baseline for if we do go ahead with the treatment and our program, but also we just want to know if they need our help at all. If hopefully, we'd like to see that they don't, but if they do have high numbers of frequency of diarrhea, then we'll go ahead and continue with the intervention. We plan on spending 1 month in the community educating and installing the dispensers. We want to spend 1 month there because we want to get comfortable with the community and we want the community to get comfortable with us. We also want to spend that much time there because we want everyone to have a chance to come and talk to us. We understand that they might be busy when we want to do an educational session, so if we make ourselves as available as possible, everyone can come talk to us at some point or another. And during these educational sessions, we want to emphasize a few things. First, the health benefits of breastfeeding for young children. We also want to talk about simple tricks to lower the spread of disease and diarrhea, and these could be things like hand washing and meal prep. We also want to teach how to use the dispensers. We don't think that'll take a lot of time or energy because there's supposed to be instructions in the language of the people on the dispensers, and that would usually mean putting it in several languages. And also they're meant to be easy to understand and easy to use, but we'd still like to go in there and just clarify exactly how to use them. 3 months later, we want to do the first checkup and assessment. So we'd like to come back 3 months later, speak with the community again, see how our solution is working, take another poll to compare to the original poll and see if there's been any increase or decrease, and if there is, change our approach accordingly. After that first initial checkup after 3 months, we want to do another checkup every 6 months until there is confidence in the autonomy of the community and also confidence in the results that we're getting. The evaluation of the intervention will, like I said, take place initially 3 months after we're done with our month-long initial meetup, and then every 6 months again, so we have a spread of information and data to look through. We're going to use the original survey numbers to compare against before we had done any changes within the community. As far as reaching and recruiting, we want to reach communities by meeting with them in person and discussing their need, discussing if they want us to be in the area at all. And we plan on recruiting volunteers from campuses across America and Europe, preferably students who have an interest in public health and have like some background knowledge and experience in the field as well. Factors that cannot be addressed, we came up with one, and it is the willingness and acceptance of the community to meet with us and embrace our solution. We understand that we're not locals, we don't completely belong in the culture or in the region or in the community at all. So we don't want to come in and just like say, this is how it's supposed to be done, you need to take our lessons and you need to apply them. Instead, we'd like to have a conversation with them and see if they'd like our help, and if they would, then we would love to meet with them and start getting into the community. That's our presentation. Thank you for listening.